Good evening, everybody, and welcome to our Diabetes Alliance Masterclass number 1. Our presenter tonight is Dr. Judy Liu, who's an endocrinologist for Hunter New England Health. Just before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. There will be an evaluation that will pop up at the end of this webinar, so please fill it in, especially for those GPs that would like their CPT points uploaded. I'll do that for you. And Thursday night we have Diabetes Masterclass number 2. So in some ways the lockdown has proven to be a great outcome for this, because we were going to do these face-to-face in Gunnedah and Narrabri, but because of the COVID situation, we're doing them online, so everybody gets to listen, which is just great. All right, I'll hand over to you. Thanks, Judy.
Thanks, Jenny. So welcome everyone, and thanks for giving up an evening. So as some of you may know, this is part of our Diabetes Alliance initiative through the Hunter New England region, and there's actually 4 masterclasses. So this will be the first one, and if you're interested in the other topics which we cover, including insulin, diabetes and pregnancy and complications, as well as obesity, you'll need to attend the other master classes. So as Jenny says, I'm one of the senior staff specialists at the John Hunter Hospital, but I have worked in pretty much most of the hospitals around our region or visited. In the Masterclass 1 section, we're really just going to talk about some of the reasons why we started the Diabetes Alliance, but particularly looking at what's the importance of type 2 diabetes, why is it important for us to screen and diagnose, and what do we understand drives the pathophysiology and therefore the complications. And then we'll talk about some of the management options. We're not going to cover insulin because, as I said, that's going to be covered in Masterclass 2 in more detail, but we'll talk about lifestyle evidence for lifestyle modifications, as well as our current non-insulin therapy. And I'll touch on the NDSS schemes, as well as some of the latest guidelines, which I think are a big improvement on previous guidelines that are now available. So I often ask these questions of medical students when they come through our hospitals, and we talk about, well, what's the definition of diabetes? And I think we can all recite the definition of diabetes, because we're all taught in medical school that, fasting glucose above 7 or random or 2 hours post 75 gram OGTT above 11.1. And then in the last decade, we've also introduced HbA1c as a diagnostic criteria above 6.5%. But when I ask people where did the numbers come from, this 7 to 11? So again, if you're having troubles remembering, just remember the petrol stations you all drive past. Where did the numbers actually come from, and what do they mean? And at this point, most people say, I don't know. It's like one of those things that get sent down from Mount Sinai. But these numbers are actually based around some early studies looking at diabetic complications. So when you go out into the population and you just routinely screen people and you don't know whether they have or don't have diabetes, that's where the numbers come from. And the most specific complication to diabetes is diabetic retinopathy, because obviously, although we know diabetes can cause heart disease and stroke and kidney failure, a lot of other things contribute to heart disease, stroke and kidney failure. But diabetic retinopathy is quite specific to diabetes. And when you look at the population average for diabetic retinopathy in those who you don't know have diabetes, you can see that once you get up into this top quintile, this top 20 ranking area, that's when the curve starts to take off. And what I've popped down there is to show you the fasting glucose at the current diagnostic cutoffs. So at a fasting glucose of 7, you can see that already 3% of the population will have, 2 to 3% of the population will have retinopathy. If you look at the cutoff of HbA1c, then that's even higher. And if you look at the 2-hour cutoff, which is the glucose of 11, then you're going to pick it up a little bit earlier. But that's where this curve, these numbers come from originally. But I guess if you think about that, it also means we're diagnosing diabetes late. It means we're diagnosing people once they've established a complication, in this case, retinopathy. Because if we really wanted to pick people up earlier, then we needed to pick them up when they were in the 14th brackets. And at that rate, you can see that the fasting plasma glucose is only 5.8, and the 2 hours is about 9, and the HbA1c is in the high 5s, so 5.7, 5.8%, because that's the point at which you now start to see the retinopathy rate start to rise. Obviously, of course, there's a lot of people who don't have retinopathy who may not go on to develop retinopathy that you'll diagnose as well. Hence, there's always a decision that needs to be made about the risk for the person. And I think that's something I really want to try to get across to GPs, because sometimes we get very stuck on 7 and 11. And what I think you need to think about is the individual risks for your patient and what does it mean to them and what's their risk. Since those early trials of retinopathy, we've had management trials, and the DCCT was a pivotal trial back in the 1980s, published in the 1990s, looking at other complications. So as I said, retinopathy is very specific for diabetes, but you can see that all of them go up as your HbA1c goes up. So your risk of nephropathy is exponentially increasing, as is your risk of neuropathy and microalbuminuria. And I think that's again important to note, because when we do alliance, I often say to the GPs, you know, you don't have to get people down to 7%. Don't spend too much time worrying about 8 to 7% if you've got a group of people who are 10 or 11%, because you can see that the reduction in the complication is much more marked if you can get someone from 11% to 10%. And that's the group you should focus on first if you're going to try to tackle diabetes in your practice. So those complications is why we care about the glucose readings and why we want to diagnose diabetes, and we want to diagnose it early so that you could actually prevent blindness and end-stage kidney disease, and then hopefully also macrovascular complications. So we've been doing Alliance through our region for some time now, and those of you who have participated know that part of our program involves looking at the data of your practice and also looking at the data of other practices to see how we all compare and to see how we're all doing. And interestingly, when we look at practice data, prevalence for diabetes varies across our different practices, and it can go from as low as 4% up to 13%. The estimated prevalence of diabetes, according to New South Wales Health data as well as national data, is that our true prevalence is probably somewhere between 10 to 12% if we diagnose everyone who should be diagnosed. But we know that a lot of people don't get diagnosed until quite late or never get diagnosed. So I guess this is just a slide to ask people what they think, or do you know what your practice prevalence is? And is it around that 10 to 12% mark? And if not, why not? And why is there such a variation across different GP practices? And I guess there's many possible reasons for that, because it depends on the sort of patient population that you see. We know socioeconomic class has something to do with it. We know how far away you are from metropolitan areas has something to do with it, as well as, you know, the proportion of high-risk populations like Aboriginal and Torres Strait Islanders. But I think one of the key things is that probably what drives a lot of the variation in prevalence is screening practices across populations. Because when we look at the practices that have high prevalence and we ask them what their system approaches are, most of those practices do routine screening rather than waiting for patients to present, asking to be screened, or waiting for patients to present symptomatic. So symptomatic diabetes is not too difficult to diagnose, you know, but people come in with osmotic symptoms. So basically they complain of thirst, they complain of polyuria. They may not present to you with those complaints because this develops generally slowly with time. And so they might just think that there's someone who likes to drink a lot of water, and because they drink a lot of water, they go to the toilet a lot, whereas it's actually the other way around. It's because they're glycosuric that they're thirsty and they're drinking lots of water. I highlighted weight loss in red because weight loss is a very important indication that the patient is about to decompensate or is decompensating and needs urgent attention. Sometimes they come because of the immune paresis of diabetes. So again, we know that diabetic patients have higher risk of lots of infections, but particularly with skin infections, thrush and urinary tract infections. So they may come to you with that. And in the very severe cases of hypoglycemia, they can actually present with blurred vision, which may be due to retinopathy or acute bleeds, but may also just be due to big osmotic changes in the lens in the eye. So the important thing is if someone does turn up and you get a history that's suggestive of symptomatic diabetes, and in particular ask them about weight loss, you should urgently do a diagnostic test. And that means that you don't have to wait for a fasting glucose, because by the time you're symptomatic, you should have a glucose that's easily in the diabetic range. So you could just check a random glucose, and often, because this has developed over a period of time, so we're talking usually months or year, a HbA1c should be positive. It's very important that you don't order an OGTT in a symptomatic patient because, as I said, if they present with osmotic symptoms, their glucose is already high. And if you then give them a big glucose load, you can actually push them into hyperosmolar syndromes and cause a complication. So we actually say, if you're symptomatic or you think they're symptomatic, just do a random glucose to check first. And if you're still worried and those things are negative, then you might consider it, but then you'll have to think of some other reasons for their symptoms. And with symptomatic diabetes, particularly if they tell you that they've got weight loss or their glucose is very high, above 17, we recommend that you do ketone testing. And in fact, you can do that at your desk if you've got the right glucose meter. So again, if you don't know what that is, please ask and we can tell you which meters are available to do that. But you can do a blood capillary ketone test, which can tell you whether they are running into insulin deficiency and how urgently we might need to get them onto therapy. The Racgp Handbook, I think most of you are familiar with this. It's been around for a number of years, and it's up to, I can't remember now what version, at least version 4. But this is the most recent version, which was updated just last year. And it does go through in detail everything that you need to know about type 2 diabetes from screening to management. But I'm just going to summarize the pages for screening for you here. So basically, the guidelines suggest that, one, obviously, if they're symptomatic, that's not screening, that is diagnosis. If they're not symptomatic and they've just come to you for routine health reviews, then we should always be thinking about diabetes and considering how to screen. If a patient is considered low risk, and that means that there is no reason they should be diabetic, there's no family history, they're not overweight, they don't come from a high-risk ethnic population, then you could screen them using the Asdrisk survey questionnaire from the age of 40. The questionnaire does take a bit of time to do, so sometimes it's most helpful just to leave that in your waiting room, and it will allow them to have them to do that's productive whilst they're waiting to see you. But that's a cheap, easy thing to do, and if they score a high on the Asdrisk questionnaire, then you would then go on to do biochemical testing, which is the blood tests. If someone has high risk, so carry risk factors for diabetes, then they should be screened every 3 years, and they shouldn't be screened with the Asdrisk because they have risk factors and the Asdrisk may miss them. So these people should be screened with a blood test, whether that be a fasting glucose or a HbA1c. And then if you're very high risk, and there's only two groups that you need to remember as being very high risk, then they should have annual screening with a blood test. And that again is either a fasting glucose and or a HbA1c. And the two groups you need to remember is Aboriginal and Torres Strait Islanders from the age of 18. And that's one, to make sure that we don't miss out opportunities for opportunistic screening, but also the fact that Aboriginal and Torres Strait Islanders have higher rates of complication and death from diabetes at a younger age and a younger BMI, a lower BMI. And they are 4 times more likely to have diabetes than the general population. So younger age is starting and annually. And then obviously, if you've already got pre-diabetes or impaired fasting glucose or impaired glucose tolerance, then you should do annual screening. Now, this can be a bit tricky sometimes because I'm trying to remember, is it every 3 years? Did I screen them last year? Did I not screen them last year? Medicare actually allows you to do a diagnostic HbA1c every year for everyone. So if nothing else, we underscreen. We don't have people over-screening. So if it's too hard to remember all this, then what I say is take the opportunity once a year, just do an annual HbA1c for your patients, and that will be allow us to do the highest pickup. Obviously, that may not be the most health economic way for us to do it as a large population, and that's where, again, coming back to your patient, determine what you think is a risk for them, and if they're considered high risk, I would do a HbA1c, because the long-term complication is much more than the cost of a HbA1c once a year, which is about $25. It's also important to know that if you're going to send people for a fasting blood glucose level, that they don't fast for too long, because the longer you fast, the more glucagon you produce and the more insulin resistant you become, which is why we always encourage breakfast. And so if they fast for more than 8 hours, you can actually get a false positive elevated fasting glucose level. So we only get them to fast for 8 hours before they go for their test, and no more than 12 hours. So what is high risk? So, high risk, and this is again not taking into account Asdrisk. If your Asdrisk score is above 12, you go on to a blood test, screening test. Otherwise, these people don't need to sit down and do a questionnaire. So if you're over age 40 and you carry extra weight, then you're already in the high risk group, and you should go straight to a blood test every 3 years. If you have a first degree relative with diabetes, particularly if they're your parents, again, you fall into high risk group. And if you've got complications from vascular disease, then that again also puts you at high risk. So if you've had a previous angina, heart attack, if you've had peripheral vascular disease or stroke, then these people should be screened every 3 years. High risk ethnicity groups, not including Aboriginals and Torres Strait, because as I said, they're in the very high risk group, but people who come from the Pacific Islands, Asian subcontinent, particularly around India, Bangladesh, Pakistan, or of Southern Europeans, so around the Mediterranean region, are also at a higher risk of diabetes. And these people, again, should be screened with blood tests every 3 years from the age of 40. If you've had gestational diabetes or polycystic ovarian syndrome, these are insulin resistant states, and obviously gestational diabetes is the first sign that you do have a limit to your beta cell abilities. This group of people also need screening every 3 years. And then there are certain medications that obviously put you at very high risk of developing diabetes, and that includes things like steroid therapy, but a lot of the antipsychotics are also associated with developing diabetes, and that includes things like olanzapine, risperidone, quetiapine to a lesser degree. So they again should be screened. And the reason we put them in high risk is these sort of studies looking at what is the likelihood of you developing diabetes if you have a risk factor. So you can see that obesity on its own, so BMI above 30, you are 7-fold more likely to develop diabetes. So that was why there's no need to do an Asdrisk assessment. You can go straight to a blood test screening. Family history gives you a 2-fold increase, and if you both parents have it, you can double that again to 5-fold increase. As I mentioned, just having Aboriginal and Torres Strait Islander heritage gives you a 4-time more likelihood, and if you're of Asian descent, then you're twice as likely than a Caucasian person to develop diabetes. I put these one in because, you know, we often get asked questions about, there's a lot in the media about extra sugar and sugar-sweetened beverages and being sedentary, and they are also risk factors, obviously, but they're not as big a risk factor as having that ethnicity or the parental heritage or the obesity. But you can see that for every 2 hours per day of sedentary behavior, you have a 20% increase in your risk. For every can of sugar-sweetened beverage, so every extra can you drink per day, you increase your risk, 80%. Smoking on its own also increases your risk of diabetes because smoking ages a lot of tissues, including pancreas. And then, as I said, we don't have good numbers for the antipsychotic use, but we know that these are strongly associated for the individuals. So how do we go about screening then for asymptomatic patients with diabetes? Normally in a face-to-face meeting, we try to use Slido for these polls, but I'll just let you think about this one for yourself, whether you screen people with a fasting glucose of 75-gram OGTT, whether you can use your desktop capillary glucose meter or whether HbA1c is a way to screen. And I think all of those are reasonable. I'll point out that 3 is not an approved screening method, but I'll show you why, you know, if that's all you've got, is still a pretty good way of screening and maybe better than using the Asdrisk assessment. In the updated guidelines, they've now put this into a nice flow chart for you, and I've stolen this straight from your guidelines. And as you can see, basically it says if you're asymptomatic and you're deemed high risk either by the Asdrisk or because of your other risk factors, then you have a choice. You can do a blood glucose, a fasting blood glucose, or you can do a HbA1c. I tend to do them together because you need 2 diagnostic criteria to diagnose diabetes, but you can do one as a screening test, but if that's positive, then they've got to go back and do the second one for the confirmation. And just to save people the time and the pain of having 2 needle pricks, I do them together. So if you're going to use a fasting glucose as your screening tool, then as we said, if you're above 7, you need to confirm this. So this doesn't confirm diabetes. You need a second diagnostic test. And so you need to repeat that fasting glucose again to show that it is still above 7, and it wasn't just the fact that they had a very large birthday cake the night before or that they fasted for too long. If you're under 5.5 fasting, then the likelihood of you having diabetes without any symptoms and being asymptomatic is low, and so you could just retest that person in 3 years. In between that is where things get a bit grayer, and this is where oral glucose tolerance tests could be used. So if you're worried that, you know, maybe they still have diabetes and you want to be absolutely certain, then you can do an oral glucose tolerance test at this point. And that is the gold standard for diagnosis. So if you really needed to exclude it, then that's what we do. And then based on your glucose tolerance test, you fall out as the 7-11, getting the diabetes, or you're not diabetic, or you fall into what we now call pre-diabetes or impaired fasting glucose, or in the old days, impaired glucose tolerance, where again, that determines whether you're going to retest them next year or whether you're going to retest in 3 years. If you do a HbA1c, then obviously there's no need for fasting. They could just have this blood test at any stage in time. It gives us a rough idea of the last 3 months, but in particular the last 1 month, how their glucose readings have been going. And so using HbA1c, the cutoff is quite high. So we're going to miss a lot of people who would be diagnosed on an oral glucose tolerance test, but we're not going to misdiagnose too many at the higher cutoff. So again, if you do a HbA1c and is above 6.5%, you need a second diagnostic test, which is why they'll have to come back and repeat the HbA1c, which isn't covered under Medicare for diagnostic purposes, because they only allow you one HbA1c unless you're known to be diabetic. And that's where sometimes these government rules don't always make sense. And that's why I like to do the fasting glucose with it. If you're below 6%, then your chance of having diabetes is quite unlikely. So you could consider them low risk and retest them in 3 years. If there's no reason for you to believe that you've got a falsely low HbA1c. And then, as I said, there's that grey group in between, where I think it's important to highlight to this group that you are pre-diabetic. And the American Diabetes Association has that pre-diabetes category, although in Australia we don't recognise that officially, but they're the group where you're going to retest them next year because they're just like the impaired fasting glucose group. I should mention that if anyone has any questions along the way, feel free, please type it into the question box and we'll try to address them at the end of the screening section. So the diagnostic criteria, because it is a life-changing diagnosis when you give a diagnosis of diabetes, so you don't want to do it just based on one result. You need to be quite certain that that is what they've got, because it will affect things like driving regulations, health insurance, life insurance, certain occupations, and it does, give them a mental health burden of a chronic disease as well. So 2 diagnostic criteria. Symptoms is included as one diagnostic criteria. So if someone has come to you with polyuria, polydipsia or thrush, and you think, I think you've got diabetes, and you've done a test and they meet the criteria because their glucose is above 11.1 or their fasting is above 7, you don't need to do a second test to confirm the diabetes. Because as I said, we're not dealing with the pre-diabetic range. We've actually diagnosed at the higher end. For the asymptomatic person, you need the 2 test results. And these need to be separated in time, because if you're under a lot of stress or you're sick, you might have stress hypoglycemia. So 2 positive results on an oral glucose tolerance test only counts as 1 occasion. So that's why, you may not want to go straight to an OGTT. You might want to use a different test on another occasion. But you need 2 results on 2 separate occasions to qualify. And oral glucose tolerance tests are a bit of a bugger to do because it takes 2 hours. The patients can't move anywhere. They need to sit for those 2 hours. They need to fast, and they need to drink a very sweet drink. Actually, there's no more sugar in the 2-hour glucose tolerance test than in a can of Coke. But people do complain that it's very sweet, and sometimes it makes them feel unwell. And because of that, 2 fasting glucose can usually diagnose most of the people we are concerned about. If you want to expedite things, because a lot of patients, it's hard enough to get them to do 1 test, they said, we'll come back and do another test on another day. This is why 2 qualifying results on the same day could be a HbA1c and a fasting glucose, or a random above 11.1, because HbA1c is not dependent on the day. So as I said, if your HbA1c was 6.5% today, it won't be 5% tomorrow. unless there's a problem with the lab. So HbA1c is a long-term analysis, and then you can pair that with an acute glucose reading. If you've got a discrepancy doing a HbA1c, so your HbA1c is high but your fasting is not high, then you haven't got two results. And that's where you might want to use an oral glucose tolerance test, because that is the gold standard. Or you repeat the abnormal tests. And as I said, with HbA1c, you probably need to delay it for at least a month before you can repeat it to show that it is still elevated and it's a problem. So we're going to do a few examples just to see if that's made a bit of sense to people. And unfortunately, like I said, it's hard to do via webinars, but please feel free to go through this in your own head. So a patient, Mr. R, presents with a fasting glucose. It's asymptomatic, so just routine screening of 7.3. The animation hasn't worked tonight, but would you be confident with the diagnosis? So hopefully you remember 2 diagnostic tests on 2 separate occasions if you're asymptomatic. So in this situation, we couldn't diagnose him just on the fasting glucose. So what other tests could you use? As I said, you could repeat the fasting glucose, or you could do a HbA1c. And in this setting, we did HbA1c, and it was 6.3%. So this is that situation where you've got 2 discordant results. He's not above 6.5%, but he is above 7. And so what tests would people do at this point? So, you know, the options would be, we repeat the fasting, and that's actually what the guideline would suggest. So you should repeat the test that's abnormal, because we're more worried about missing the diagnosis of diabetes than not in people who've got 1 positive test. You could repeat the HbA1c, but again, you're going to have to wait at least a month to allow the hemoglobin to refresh or to change to see if it's still elevated or going higher. Or you could, in this instance, do a 75-gram oral glucose test, because often if they're a bit borderline, the gold standard test would be to do that. And all of those are reasonable options. I think most people would just repeat the fasting glucose. A third alternative is just to consider the person pre-diabetic and start discussing what to do with pre-diabetes. I'm going to go on to example 2. So this is a bit clearer. So this is Mr. M with a fasting glucose just on routine screening tests of 12, who's asymptomatic. So again, the same options. Do you repeat the fasting? Do you do a HbA1c, or do you do a 75-gram oral glucose tolerance test? Now, there's a subtle difference between this case and the last case. And I think what you will notice is that the last case had a fasting of 7.3, just above our target, whereas in this case, the fasting is well above our target at 12. So the main point about a case like this one is do not do the oral glucose tolerance test. You can do a HbA1c because the HbA1c should be clearly elevated if that's the average glucose and there's no issues with his blood. Or you could recheck the fasting, but please don't send this person for a 75-gram oral glucose tolerance test. We get plenty of referrals every year where GPs have sent their patients to a glucose tolerance test when the fasting is already elevated, and then we get these horrific 2 hours postprandial readings, plus patients feeling very unwell. And the problem with HHS is you can precipitate strokes. So it's not a benign thing to do to push people's sugars up into the 30s and 40s. So in this setting, if you've got a very elevated fasting, don't do a glucose tolerance test. Repeat the check, repeat the fasting, or even do a random, or do a HbA1c. So as you can see, we've moved away over the last decade or so from routinely ordering glucose tolerance tests, although they remain gold standard for borderline cases or situations where HbA1c is not helpful. So it is indicated for universal screening for gestational diabetes. And I put in 24 to 28 weeks because that's at the gestation at which we screen for gestational diabetes. We don't recommend that you do this in the first trimester because in the first trimester, and this is covered in talk 3, high glucose is teratogenic. And so you don't want to push women in the first trimester into high glucose readings, which can potentially cause fetal malformations. So in GDM, at 24 to 28 weeks, in women who otherwise have not been diagnosed with diabetes and are, not high risk, you could do a glucose tolerance test. But in this setting, we're not interested in retinopathy outcomes. So we're not worried about whether the mother has retinopathy. What we're interested in is in the fetal outcome. And because of fetal outcomes, you can see that the diagnostic criteria are much lower. And again, we talk about this a lot more in the diabetes in pregnancy discussion. But I think it's important to highlight that, if this is the level at which we're causing damage to developing DNA, then it's not surprising that pre-diabetes is a condition we should care about because these are the pre-diabetic region numbers. If you do think that a woman might have diabetes early in pregnancy, then we actually recommend you do a fasting glucose with a HbA1c or even a random glucose. At this stage in time, we don't know what is a good fasting glucose to have in a young female in early trimester. So we use the gestational cutoff at 24 to 28 weeks until we get more trial evidence of what is an appropriate glucose reading. But if you're going to do it, like I said, we want to see women with fasting glucose above 5 in first trimester. Outside of pregnancy, we use glucose tolerance tests to try to work out those borderline cases. So where you've got discrepancies between the fasting and a high HbA1c, because that's only 2 things that's going to give us this sort of scenario when you break it down. It means that they must rise very high when they're not fasting, so after a glucose load, or there's a problem with the HbA1c. And that's where a glucose tolerance test can determine that, because if you've got a normal glucose tolerance test and the HbA1c remains high, then we know that we shouldn't use HbA1c as our marker for glucose levels in this person, because they may have something unusual going on with the hemoglobin. Similarly, if you really need to determine if they have diabetes, either because it's a health clearance for a job like a pilot or for a train driver or commercial drivers, then you could use an OGTT to definitively rule in or out diabetes. Please don't order insulin levels for oral glucose tolerance tests because they're kind of artificial, because you don't normally go around eating or drinking 75 grams of anhydrous glucose. And so measuring the insulin levels doesn't actually help us and can often confuse doctors and patients about what that actually means, if their level goes up or if their level doesn't go up enough. So we only do insulin levels in very specific circumstances. So I'm going to give you example 4. So this again looking at screening and diagnosis. So this is a 48-year-old overweight truck driver who holds a HR license, so a heavy rigid. And because they're overweight and they're over the age of 40, they get a screening test. In this case, an OGTT was requested, which has returned a fasting under 7 but are 2 hours above that 11 mark, and the man is asymptomatic. To help work this out further, the GPs ordered a HbA1c, which comes back at 5.6%. So this is where things get a bit trickier. Should you diagnose the person with diabetes? Should you tell them that they're okay, they're not diabetic, and they should just happily go on their way? And if I do tell them that they have diabetes, what will be the consequences for the person? And so there's a lot to weigh up here, because obviously when you look at this, you say, this is a high-risk individual, relatively young, obese, overweight, with at least impaired glucose tolerance. So very high risk of going on to diabetes, or maybe early diabetes. Because as I said, when you look at that graph I showed you earlier on, there is no clear line at which point you can just say, that's the line in the sand. We have artificially drawn a line in the sand, but it's a spectrum. And it's just at what point do you want to say the spectrum is pathological for the person. But I guess, you know, sticking strictly to definitions, I would not diagnose this gentleman with diabetes, because it has major implications for them. Because once you've diagnosed diabetes, it's much harder to then remove the diagnosis of diabetes, particularly for driving and job requirements. But I also wouldn't tell them that they are normal. So we've had patients go, my GP told me it was fine, that I wasn't diabetic, despite a HbA1c of 5.8, 6.1%. So this is a sort of person where, there's consequences to diagnosis, but there's also consequences to false reassurance. So we always weigh up, what's the main driver. If the person had actually come in and it wasn't a screening glucose tolerance test and has actually had a heart attack, then I think there's a lot more evidence for us to say maybe we should be intervening at this point with more than just lifestyle. So whenever there's a question about driving, you could go to the Fitness to Drive booklet, which is available online. As you're all well aware, anything above an LR requires an endocrinologist anyway to sign off, according to the RMS, the National Australian Transport. So you could just send them to us for review at this point as well, and we'd be quite happy to try to see them. Unfortunately, we can't do that in the public clinics, just because our public clinics are so overwhelmed with referrals for people with frank and complicated diabetes. But like I said, certainly they're the group where we are already starting to be worried, and referral to a private endocrinologist would be recommended. So I showed this graph for HbA1c for diagnosis, because over the last 10 years, because of issues with the variability in glucose testing, as well as the complexity of 2-hour glucose tolerance tests and the failure of patients to actually follow through requests for these, HbA1c has become part of the diagnostic workup. But I put this graph, and this graph comes from a Chinese population, but there are graphs from populations all around the world with roughly the same sensitivity and specificity. But you can see that it's not a perfect ROC curve, which means we're always going to have to sacrifice something, no matter what HbA1c we pick. Either we're going to miss a lot of diagnosis, or we're going to diagnose a lot of people unnecessarily, who we don't have to worry about into the future. And that's why at a HbA1c of 6.5%, that was deemed to be appropriate for most populations, because at that point you can see that the specificity is over 90, they have around 95% in Caucasian populations. But you're not going to diagnose too many people with diabetes who don't have diabetes on a glucose tolerance test. So you're not going to misdiagnose people. But you can see that the sensitivity is only around 70%, which means 1 in 3 people will have diagnostic criteria diabetes on glucose tolerance tests, but will be missed purely on a HbA1c. And you could argue that they are early diabetic patients or mild diabetes, but because you're going to miss 1 in 3 on an oral glucose tolerance test, that's why there's still a role for using glucose tolerance test for that group. But you can be quite comfortable that you're not going to tell someone they've got diabetes incorrectly in the majority of people. When can it go wrong? So when can we actually falsely reassure or diagnose people incorrectly? And this is why HbA1c does have its limitations. And so just to be aware, HbA1c is hemoglobin A1. So hemoglobin A1 is the main hemoglobin in adult populations. But there are other types of hemoglobin around the world. And so anything that affects your hemoglobin levels or your red cell survival or the proportion of blood that might be A1 will affect your HbA1c. And this is just a small table, but there's a lot of other things. So anything that affects erythropoiesis, so iron deficiency, B12 deficiency, if you need to use EPO, which tends to, get your red cells to be produced at a higher rate, then that's going to affect your HbA1c. If you've got funny hemoglobin, so you don't have normal amounts of hemoglobin A1, you've got sickle cell or you've got thalassemia, there's a whole bunch of hemoglobins around the world. If you've had a recent acute blood loss where you might be making a lot more fetal hemoglobin to compensate, will affect your HbA1c. Lots of things will affect the ability of glucose to attach to the hemoglobin A1. Or they can interfere with the actual way we measure in the lab, so assay interference. So that's where things like, high dose aspirin over long periods of time, or vitamin C, again at higher doses, can interfere with HbA1c. There's also genetic determinants that allows certain higher or lower levels of HbA1c for complication rates. Anything that affects how long the red cells survive for, so whether you have a large spleen or you don't have a spleen, is a big predictor. Drugs that obviously increase red cell death, such as dapsone therapy, again, will affect HbA1c. And then there's a whole bunch of assay-related issues, which can be hard to work out and is assay dependent. But this is where you look at the HbA1c, you look at the glucose readings, and you go, there's a disconnect here. That's where, people like myself will come in, or chats to your biochemist to see if you can work out if there's an assay issue, or sending it to a different lab that uses a different assay may help work it out. But because of all of this, just be aware that sometimes HbA1c may not be the be-all and end-all to glucose levels and glucose control. And with the era of continuous glucose sensors, we use a lot of continuous glucose sensors now to tell us if we should or shouldn't be worried about the HbA1c discordance. As some of you may have in your practice, we now have point-of-care HbA1c machines, which you can purchase and do on-the-spot HbA1c. They're getting increasingly cheaper, although they're still more expensive than the lab. They're still prone to some errors. There are some machines that are as accurate as the lab, but there are some machines which aren't. So depending on what you've got at point of care, you can get a variance of up to 0.4%. And that could make you go from 6.2% to 6.6. And you can see where that could be a problem, because at 6.6, I'll say you have diabetes. At 6.2, I say you don't have diabetes. So we don't recommend point of care HbA1c testing to diagnose, but can certainly be helpful for monitoring patients' progress. And if you're in remote areas of the country or in communities where the lab might be a very long distance away, that's where point of care HbA1c could be used. I'm going to stop and just see if there's any. I think there's a question potentially, Jenny, about screening before I move on to pre-diabetes.
Yes, there are a couple of questions. The first one is sort of more of a statement that seems sugar is worse than smoking as a risk factor.
That's per can for diabetes, but obviously smoking has a lot of other negative association, such as cancer, which sugar hasn't been directly linked with.
What are your thoughts on fasting insulin as a predictor for future type 2 in people who return negative screening tests?
I think, you know, in the research setting, fasting insulin can help determine insulin resistance. So you could use it to calculate a HOMA-IR, but I think it really comes down to what does it mean for the patient in front of you. And if that's the only thing that tells me that they're insulin resistant, I probably wouldn't worry, because I think there are better markers of insulin resistance, and we'll talk about some of the clinical signs when we talk about the clinical manifestations of insulin resistance. So I think what we prefer is that GPs don't order insulin, because it really carries extra benefit to you, although it has a role in the research setting when we're talking about pre-diabetes and insulin resistance. But if you are going to order it, you need to have a thought to what you're going to do with the result at the end of the day. And that's why if someone's already overweight with a family history, I probably don't need an insulin level to tell me that they are very likely to have insulin resistance, or that they're going to get more insulin resistant with time. And as I mentioned, there's a lot of variability for insulin resistance. So, you know, if you fast for too long, you change insulin resistance. Your weight has a big factor on insulin resistance. Whether or not you had a good night's sleep has an influence on insulin resistance. So fasting insulin at a clinical level, I don't think we're quite there yet for use. And I would use other parameters to help me determine whether I need to treat my patients for pre-diabetes or not.
Okay. Can you do HbA1c if FBS was 5.5 and above instead of OGTT?
Sorry, can you do a
HbA1c instead of an OGTT?
So the government allows one diagnostic HbA1c per year under the MBS, unless you label your patient as diabetic, in which case then they're allowed to have 4 HbA1cs under Medicare. So you could do so as I said, I often pair them together because HbA1c is a longer term marker. So where I've got a case where I'm not sure whether they should be diagnosed or should not be diagnosed, it becomes part of the equation. Oral glucose tolerance test is still the gold standard, and 2 oral glucose tolerance tests would be the standard, but you often don't need to repeat a whole test. You just need to repeat the abnormal result. So if it was a 2-hour result that was abnormal, then technically, yes, you need to repeat the whole test, but if it was just a fasting, then you can just do the fasting. Randoms, depending on what they're drinking and eating, can be helpful. But I think, like I said, I think what I'm trying to show you in the earlier slide is that it's a spectrum. So even at the high HbA1cs, not everyone gets retinopathy or complications. So there may be certain things that are protective, and there may be things that are not protective. So, and we talk about metabolically healthy, obese people that don't really exist in truth, but there are people who have more protective factors, which mean that they can get to a heavier weight before they run into metabolic complications like diabetes and others. So I think when you've got that person in front of you, you need to weigh a lot of things up. the younger they are, the more worried I am, the more I want to make the diagnosis clearly, because they've got a lot longer to develop complications. If they've already got complications, then it's important. So if they've got, infections, or they've got, polycystic ovarian syndromes with infertility, then, I want to make those diagnoses earlier. But if they're 60 years old and they've got other conditions that are, affecting their quality or quantity of life more than diabetes, I may not need to make that diagnosis of pre-diabetes as early. So I think you do need to think about who's in front of you and what does it actually mean, both to them from a diagnosis perspective, but also from a management perspective, because you want to be able to give them meaningful interventions in the longer term, because it's not the glucose that we care about, it's the complications of glucose with time. Obviously, we care about glucose when it's very, very high or it's very low. Again, not going to be a factor until you start treating. But otherwise, in the range of that grey zone area, is really about trying to predict that person's individual risk for going on to develop microvascular complications. And that's where things, I think, gets a little bit more subtle, and there's a bit more art in how comfortable you are with the person in front of you. Because some people, that if you give them the diagnosis of pre-diabetes, their anxiety is going to go through the roof, and everything's going to be made much worse. Whereas some people, you need to give them the diagnosis of pre-diabetes because you need them to start taking some ownership and making some health decisions for themselves. I hope that kind of answers that question.
What do you do if pre-diabetes is treated with metformin? What criteria then for diabetes?
Yeah, so, the government doesn't actually approve any medications for treatment of pre-diabetes at this point in time. And I'll show you some of the metformin data. We took a lot of it out of this talk because there's a lot of other things to cover. But you could certainly use metformin for pre-diabetes, which in some ways is also the initial treatment for early diabetes. So it allows you to delay the diagnosis, the official diagnosis of diabetes. And that could be important for, like I said, younger people, people whose livelihood depends on whether they do or don't have a diagnosis of diabetes. And it still helps protect them, because the long-term aim is the lower you can keep the HbA1c and the longer you can keep the HbA1c down, the more benefit they're going to have in the long term from micro and macrovascular complications. So the diagnostic criteria doesn't change, but it does mean that we can often push out the point at which they're going to cross the diagnostic threshold for when you might add on a second agent or officially give them the diagnosis. It is tricky though, because like I said, you can't do more than one HbA1c per year under the MBS without that diagnosis of diabetes. And that's why we weigh all of this up when we talk to patients about, get a better understanding of what does it mean for their lifestyle, how often can I do a HbA1c without the diagnosis, can they afford to pay for it, all of those sort of more difficult questions. But certainly metformin is well recognised as being useful for pre-diabetes.
One more, any update / advice on the effect of artificial sweeteners to diabetes risk in long term? Example, effect on weight.
So artificial sweeteners do have a small effect on the risk of progression to obesity and therefore onto the risk of progression to diabetes. So they're not directly linked to diabetes, but we do know that people who use artificial sweeteners tend to have more weight gain, and it might have something to do with the way appetite is regulated. So talk number 4, for those who really want to get into obesity and appetite regulation. I try to get people away from sweet drinks and sweet things generally, because I know that the taste receptors are directly connected to the appetite regulation centers. And therefore, even though I don't absorb sugar, by triggering sweet taste receptors, I am changing the way people view or look for different types of food. And so I try to get people, firstly, if they are really attached to sweetened beverages like full strength soft drinks and then can't consider going to less sweet things, I try to get them at least off onto artificial sweeteners. But over time, I try to get them off the diet drinks back onto just straight, water, or water with a squeeze of lime or lemon or mint or whatever flavoring they need. But I think that, humans have evolved to drink water. And so people who say that they don't like the taste of water, I think is a sign to us that our culture and our society's moved well in the wrong direction. But you just got to slowly work with who you've got. And if you can't get them off sugary drinks, at least get them onto sweeteners. And then I start trying to get them to dilute down to make it less and less sweet with time. But it's not equivalent to water, basically. All right, I'm going to push on. We'll talk about pre-diabetes. So as I said, we've set a pretty high benchmark for diagnosing diabetes. We're diagnosing diabetes at the point where 3% of the population has already got a complication from the disease. And so if we really want to try to tackle people before they get retinopathy, we really should be looking at a lower cutoff. And again, you just got to be aware that the lower our cutoff, the more people that we're going to diagnose who may not then get a complication. And that may or may not have impacts for their life. But pre-diabetes is important, and it's replaced the previous terms of impaired fasting glucose and impaired glucose tolerance for a lot of people like myself, because I think those terms are a little bit confusing. Whereas the term pre-diabetes makes it very clear. You are on the verge of getting diabetes. You are not in the normal category, and we need to do something. That's really what we want to get the message across. As I mentioned, the American Diabetes Association has put a HbA1c value on what is considered pre-diabetes. And again, based on those early and repeated retinopathy data, because the one I showed you was actually repeated when they looked at HbA1c, because HbA1c was not available when the original glucose diagnostic criteria was set. And looking at that data, basically, if your HbA1c is in the high 5%, you're on the pre-diabetes range. So between 5.7 to 6.4%, you could diagnose pre-diabetes. As I said, a third of diabetics on oral glucose tolerance tests will have a HbA1c below 6.5% when they first get diagnosed. So some of these people will have diabetes purely on oral glucose tolerance test criteria. But if you're not going to go to that point, then at the very minimum, diagnose them as having pre-diabetes if you want to change the trajectory of their vascular and microvascular complications. So why do we care? So this is why we care about pre-diabetes, because as I said, we looked at microvascular complications, but most people don't die of microvascular complications. They die of macrovascular complications. So if you look at people with macrovascular disease, so this is coronary heart disease and stroke, you can see that there's a similar exponential curve with mean fasting glucose. So as I said, we diagnose diabetes when your mean fasting glucose is 7. But you can see that the hazard ratio is well above 1 at that point, in keeping with the fact that people really started to have complications in their eyes. And then if we really wanted to pick the lowest level, then if you remember the gestational diabetes, the fetal outcome data, we're sitting in the low 5s. And that's consistent with what we see for macrovascular disease, which means that if I know that my sugar is already 6, I shouldn't be complacent that I'm not at risk of complications. I am certainly now getting into risk of macrovascular complications. Stroke is a lot more variable, and that's because blood pressure plays such a big role in stroke. But even with the bouncing around in the stroke, you can see that, again, around that low 5 mark is the point at which people have the lowest risk of a stroke event, and, you know, increasing as you get higher. And this is just a forest plot looking at a meta-analysis of a few different trials and pulling people together, looking at what the hazard ratio is, again, for people with heart disease, with or without known diabetes at baseline. And again, as you can see, you know, at around that 5.6 mark, or in the low 5s, is the lowest risk. So pre-diabetes is important because it predicts your progression to diabetes, and it predicts your risk of macrovascular disease. And that's why I said if someone had come in with a heart attack and their fasting is 6.5, I would already want to treat that person because they've already got a complication which I know is linked to glucose, even though they haven't crossed the magical diagnostic line. But this is someone at high risk of progression with macrovascular disease. It's also an opportunity to try to get people to recognize their risk and do something about it before they come back with their heart attack or their complications. So the question was asked, what about metformin? What about lifestyle? So with pre-diabetes, we still recommend lifestyle promotion first because we know that exercise, nutrition, and weight control all plays a big role in insulin resistance and pre-diabetes, and plays a big role for other conditions like arthritis, cancer, fertility. There's been quite a number of trials looking at what interventions work in pre-diabetes, and basically most interventions will work for pre-diabetes. But the biggest problem, I think, is long-term maintenance of lifestyle intervention. So the Finnish did a Finnish diabetes study where they followed people with pre-diabetes for 7 years, where with one arm, these are randomized controlled trial, one arm was given lifestyle modification advice and education, and one arm was not. And over that 7 years, they showed a 40% reduction with lifestyle modifications between the arm that was given lifestyle advice and the arm that wasn't. The difference in weight was minimal. So 3.5 kilos at the end of the 7 years. So that's reassuring to say you don't have to ask your patient to lose 10, 15 kilos to make a difference to their risk of progressing to diabetes. We're talking about, you know, 3 to 5 kilogram weight loss to show benefit. And that's why a lot of trials look at a 5% body weight reduction for meaningful health outcomes. The DPP is another randomized trial. They had 3 arms. They had lifestyle, metformin, or standard therapy. They used metformin 500 milligrams BD. And again, you can see that there's a benefit for treatment with a reduction of 58%. Interestingly, lifestyle intervention did better than metformin alone. So, you know, giving people metformin is helpful, but getting them to take metformin, they didn't have both arms together, but certainly there's still a role for exercise and weight control and nutrition changes. So lifestyle promotion definitely has a role. Long-term weight maintenance has always been difficult, but even without the weight maintenance, you can delay the progression to diabetes. We talked about smoking earlier on. So very important that people stop smoking for a number of reasons, and this is just an added one that you could throw in if you've got someone with smoking. But we know that diabetes complications are magnified if there's smoking as well. So not only does it make you more likely to get diabetes, but it makes you more likely to get diabetic complications when you are diabetic, hence the importance of smoking cessation. We've moved away from just giving everyone statin therapy, and it's recommended now that you do a cardiovascular risk assessment. And if that cardiovascular risk assessment, which is on all the standard software that available in the GP practice is above 10%, then they should have primary prevention with statin therapy. The American College of Cardiologists has actually lowered that to 7.5%. And so again, I think this is where it's worth individualizing. If I have a young person who's got a much longer potential to benefit from aggressive therapy, or or even modest therapy, but for longer periods of time, I would want to think about statin therapy earlier than if I have someone who's quite late in life, where a lot of their cardiovascular risk is fixed. But at least at the moment, 10% is what the Australian Cardiology Association and Heart Foundation is using for our primary prevention therapy. And weight control is difficult long-term with diet and exercise, and there's been lots of very big trials, very motivated patients, very motivated teams showing that we can't maintain this, and a lot of this is to do with hormonal regulation as well as the environments we live in. So if the BMI is above 40 and they've got pre-diabetes, that is an indication for bariatric surgery if the patient can access it. And I guess that's a long-standing controversial area for trying to get our government to see this as a chronic disease. And I put there as a controversial question mark, but there's actually a lot of data now that if we intervene earlier, we can prevent a lot of health complications. And so at this stage, the PBS doesn't allow it, but that doesn't mean that you shouldn't have a discussion with your patients about whether they'd be willing or able to afford paying for therapy when they're in the pre-diabetic group. It's a bit like osteoporosis though, because if I treat you earlier, you may not fracture. And if you don't fracture, you may never get onto a qualifying list for PBS. But I think for most people, avoiding the complication may be worthwhile financial investment. So I think it's still worth having a discussion about newer agents, particularly GLP-1s. And metformin is very cheap. So even though it's not technically approved under the PBS for pre-diabetes, people use it for PCOS and other conditions of insulin resistance, and people can usually afford that even off the PBS. So we're going to move into the second part, and I'm going to go through the pathophysiology of type 2. I do this in a bit of detail because I think it helps you to understand the management algorithms a bit better if you understand what the different parts of the of our understanding of the causes of type 2 diabetes is. This is a very old slide. So you can see it's from 1999. It's the understanding of diabetes. It may not be strictly true, so I'll acknowledge that straight up, but I think it's a good cartoon way of thinking about diabetes. So, we think of diabetes as a condition of aging. So as you get older, you accumulate life stresses and you accumulate weight, and you also accumulate aging of the pancreas. Insulin resistance goes with weight gain and loss of muscle mass. And so we know from age 30, we start to all develop sarcopenia and we all start to lose muscle mass. So our insulin resistance tends to go up as we get older. Our muscle mass drops and we tend to put on weight. We can match our insulin resistance with our increasing our insulin requirement so that our blood glucose levels does not change and we're not diabetic. But at some point, we're going to start showing that impaired glucose tolerance, and that predates frank diabetes by, it's about 5 years or so. And then as you get older and your pancreas gets older and it's worked really hard to deal with the insulin resistance, the pancreas starts to fail and insulin levels drop. And that is not so controversial because one of the things we don't highlight is diabetes in the very elderly. If you're diagnosing diabetes for the first time in a 75-year-old or 80-year-old, they're generally not driven by insulin resistance. They're generally driven by loss of beta cells, loss of insulin production. So you shouldn't be surprised if you need to progress more rapidly through management algorithms, or the fact that you might need to give them insulin early in the picture. They may not, often aren't that overweight in that higher age group. The insulin level, as I said, drops as the beta cell functions decline, which is a problem of age, which is why 25% of people over the age of 70 have diabetes, regardless of their weight. Hepatic glucose increases as insulin levels drop. So your ability to suppress glucagon is directly correlated with the insulin level. So as a result, you start to put out more glucose from your liver. And again, breaking down muscles and proteins to do that, and glycogen. And then as time goes on, the glucose levels rise. And at that magical point of 7 and 11, we say you now have diabetes. And that's also the point at which we diagnose the microvascular complications in our population. But you can see that macrovascular complications develop years earlier when you're in that pre-diabetes phase. So Ralph DeFronzo is a big guru of diabetes pathogenesis, involved in pretty much every large RCT trial over the last couple of decades. And he's come up with what he calls the ominous octet, which is the 8 reasons why people develop diabetes. And again, if you're really putting a lot of thought behind this, different patients have different points at which things are interfering, causing their diabetes. And for these 8 problems, from the gut to the pancreas being able to make insulin, to the liver being able to turn off glucose, to the kidneys being able to excrete glucose or not, and to the problems of muscle and fat, we do have treatment options. And that, I think, is also why diabetes is becoming very tricky. And in the next year or two, we'll have even more classes available. So when you see a person and you're thinking about, well, what's driving diabetes? And insulin resistant is a big one. So Metformin is used for type 2 diabetes first line because most people will have insulin resistance at diagnosis. And so if you're looking for signs of insulin resistance, then waist circumference, waist hip circumference, BMI, or central adiposity are the key things that determines insulin resistance. Neck circumference, to a lesser degree, correlates with insulin resistance. I don't know that many people measuring neck circumference though, but it's helpful if you're looking for things like sleep apnea. I always look for acanthosis, and the best places to look for acanthosis is under the arm. So I often say, if you look at Lady Gaga dancing, or you look at Madonna dancing, or any of these thin, very fit people, they lift their arm up and it's the same colored skin as the rest of their body. But a lot of people lift their arm up and it's brown, it's shadowed. It's not that classical acanthosis of severe insulin resistance in the textbook. Often it's just a browning of the skin, and that's acanthosis. A lot of people think that this is ethnic, you know. It's part of my ethnicity that I have dark circles under my eyes, or that my knuckles are darker than my fingers. But that's because they're in high-risk ethnic groups, and these groups are insulin resistant. So you can look at a lot of Southeast Asians and Indian population, and you can see acanthosis around their neck, around their eyes, over their knuckles. In Caucasian populations, I get them to lift their arms because they may not have acanthosis because they don't pigment as well, but what they have is cutaneous skin tags. And again, you see those around the neck and you see those under the axilla. And that's a sign to you that IGF-1 is elevated and that insulin resistance is up. And the more of that you have, the higher the insulin resistance. Interestingly, lipodystrophic syndromes, which are considered rare for the true lipodystrophic, where we can do a gene test, also predicts insulin resistance. But this is that lemon on a stick pattern that you associate with Cushing's disease. But if you think about our indigenous population, a lot of them have that lemon on a stick picture where they've got very thin arms and legs and all their adiposity is central. Same sort of picture that you see in Southeast Asian populations as well. If you're seeing very skinny arms and legs, then insulin resistance is a big driver for those sort of people, and that's where you want to maximize things that improve insulin resistance rather than necessarily targeting insulin deficiency. This is a real case of one of my patients, Miss K. She was actually a bit younger than that when she first turned up to a regional hospital in GP. She was obese, as is 2/3 of our population. She presented with weight loss, thirst and polyuria, which obviously should trigger a question about diabetes, and point of glucose test was 17 millimoles per litre. The GP advised her to have an oral glucose tolerance test on the Monday, because it was a Friday. Can anyone think about what the problem might have been for this person? I don't expect any answers because you're all muted. But there are obviously risk of delaying a diagnosis because she's quite hyperglycemic, and she's got polyuria, and she's got weight loss, and she's young. Does she need an oral glucose tolerance test? Hopefully by now you remember that we said please don't do it if the fasting or random glucose is already high, because we don't really need to push them any higher. And what should we do? I'll come back to her, hopefully if I remember to, because we'll talk about young people and diabetes. I put this one in because, as I said, we don't use point of care glucose testing for diagnosis because of variability. But over the years, glucose meters have been improving in accuracy. So this is a MARD of the brand of glucose machine that we use in the hospital, which also allows ketone testing. And as you can see, this is against the gold standard plasma glucose. And it's pretty close. So, you know, it's not, if your machine is not too old and your strips are in date and stored appropriately, you can be reassured that your point of care glucose test is going to be pretty accurate, and so that you don't need to worry too much that the formal is going to vary significantly for that person. Still don't want to use it to diagnose because I still want a second a formal test, but you don't need to delay the diagnosis or to start treatment. This is to remind us that there is more than 2 types of diabetes. So we talk about type 2 diabetes in Alliance, but 5 to 10% of the population have type 1. A good proportion of type 1s actually have type 3 if we go looking for the other causes. But as you can see, type 3, there's a whole bunch of other things that gives us diabetes, but they make up less than 5% of the patients that we see. So as a result, we're all pretty lazy and it's too long, that list, to remember. So we chuck everyone into type 2, which basically means I don't know why you have diabetes. So I'm just going to put you into the idiopathic or the polygenetic environmental causes of diabetes. But it's always worth thinking about when you see someone who you think, I'm surprised you have type 2 diabetes because you don't fit my usual phenotype, or where you've got very strong family history, to at least think about whether they might have a different type. We're always very happy to see these ones if you think that might be the case, to help work out whether they do or don't have other conditions. So Ms. K turned out not to make it through the weekend and presented with keto acidosis. So the reason to put this in is that, you know, obesity on its own, although strongly correlated with type 2 diabetes, having type 1 diabetes does not protect you from obesity before you get the diagnosis. You certainly lose weight if you have type 1 and you're not on treatment, but often you get to keto acidosis before you get to being thin and underweight. So type 1 diabetes can occur at any age. The younger you are, the more likely you are to have type 1 diabetes. But we've diagnosed type 1 diabetes in 60-year-olds, 70-year-olds with antibody positivity. In the 80-plus-year-olds, like I said, they may not have the antibodies, but they behave more like type 1s because they lose the beta cell production, so they don't make the insulin. So always be cautious with that older group or the weight loss group. They present with weight loss because they can't make insulin, and therefore they need to burn fat to produce energy stores, and by burning fat, they're going to lose weight, and they'll also lose some weight from dehydration, but they'll make ketones. So if you see someone and you've got the capacity to, I strongly encourage you to get a meter that does point of care ketone testing, and you can check the point of care ketones there and then when you do the blood glucose level, and that could tell you whether you should send this person straight to emergency or call one of us, or whether you can buy some time to start treatment a bit more slowly. But as I said, if you do test it, then it's positive. That indicates insulin deficiency, and they need urgent insulin initiation, even if they're obese. So sadly, half of our type 1s are obese in our young people's population. So that doesn't, there isn't a rising prevalence of type 2 in the young, but it's not strong enough that you can discount type 1. So who should you screen for then? And a lot of this work has been done in Australia, looking at adult onset type 1s, because often they don't present as the kids do with the sort of crash and burn picture of DKA. They can develop their type 1s a lot more slowly, depending on the number of antibodies that they have. So if you're under the age of 50, and certainly under the age of 40, I will just routinely screen to make sure they don't have type 1. Acute symptoms, so they come to you with a very short story of polyuria, polydipsia. Obviously, if they're in the normal weight bracket, so their phenotype doesn't fit with type 2, or they've got another history of autoimmunity. They've got Hashimoto's thyroiditis, or they've got Graves' disease, or they've got celiac disease. Think about type 1 diabetes. And the studies have shown that if you've got 2 or more of these, then you're going to pick up the majority of people with autoimmune type 1 diabetes. Other things that will make me think about screening them would be no family history of type 2 diabetes, which we know is strongly genetically related, even though it's a polygenetic condition. Presence of ketones, other people in the family with autoimmunity. When you look for the insulin resistance signs and you don't see any, you think about it. Or they've got very labile blood glucose patterns, and that's again a sign that the insulin production is starting to fail. You should think about it. The good news is that screening is pretty easy. So in some ways, if nothing else, I don't even need you to think about it. If it even crosses your mind, just screen. Similar to diabetes, you could sit down and think about 3 yearly Asdrisk or blood tests, or you can just screen. So with screening for type 1, what we do is we check their autoantibodies. Early on in the disease, about 80 to 90% will have GAD positivity. So you could do that as part of your screening tests for diabetes. They don't need to fast, and you just ask for an anti-GAD. In the group of people who don't have GAD positivity, half of them will have zinc transporter 8 antibodies. And that's how we came about diagnosing zinc transporter 8 antibodies. I put a little star there because zinc transporter 8 antibodies is not covered under Medicare. And you don't need to order on everyone. So I don't always routinely ask for it straight up. I check to see if they can afford to pay for it or not. It's about $30. And I only really need it if they're GAD negative, because otherwise my diagnosis can be made on the GAD positivity. Anti-IA2 are much rarer. So you can see, 19% have IA2, but IA2 antibodies are very destructive. And that means that if they're present, you can expect this person to progress to insulin deficiency very quickly. So routinely, kids who have type 1 diabetes have IA2 positivity. Adults may or may not have IA2. And so that is covered under Medicare as an autoantibody test. So if you wanted to think about how much time have I got, you could consider requesting IA2. The other antibodies are present, but they're also present in the background population, and their relationship to type 1 diabetes is not as clear, so not as helpful. But obviously, the more antibodies you have, the more likely you are to progress to insulin deficiency. So islet cell antibodies are frequently ordered. Do not order insulin antibodies. That's a different condition. That's not type 1 diabetes, and just confuses the picture if it's ordered, because there's a high false positive and negative rates. And then in the group where you're thinking, you know, you look like a type 1, and your antibodies are negative, but I wonder if you're making enough insulin, you could do C-peptide testing as well. If it's unlikely that your patient's going to do all of this on multiple occasions, you could do it in the one test, because that also gives you an idea about reserves of insulin production. And as you can see down below, that's just a graph showing the sensitivity and specificity. So you can see IA2 antibody only seen in people with type 1 diabetes, because it's very destructive, but a lot of people with type 1 will not have them. GAD, most people will have GAD antibodies positive in the first few years, but then it declines. So again, if it's 20 years down, the GAD antibody may be negative, but that's where C-peptide is helpful. And then, as I said, zinc transporter 8 for that group that's GAD negative. So when do you need to seek advice from one of us early on? Well, you know, we're always there to help you. So if you're concerned, feel free to contact us, send us a referral. We can always send you back a reply. Try not to ring us unless you absolutely have to, because we get about 40 phone calls a day through our service. So we much prefer, if it's a non-urgent request, just put it into a referral, and we triage those on a daily basis, and you'll get a reply in a written form if we don't need to see your patient. But we would like to see people who are very hypoglycemic, at risk of HHS. Obviously, people who are unwell and dehydrated, who need early admission or resuscitation. Presence of ketones, whether that be in urine or in blood, because again, that indicates early need to start insulin. Anyone who has recurrent hypoglycemia, this is not for newly diagnosed type 2s, obviously, but this is on pathways about when to contact us. And if the HbA1c is very, very high, then often you would need to give these people insulin, at least initially, to remove the glucose toxicity before you can go on to other therapy. I'm going to skip past this because I want to get on to treatment in the last half hour and a little bit about dietary. I think people make dietary advice too complex for most patients. So if a good source for guides to healthy eating is, it's good to have a quick idea of what your patients eat. So if you do Alliance, you'll see we use a lot of food glucose diaries. We get people to record what they eat for 4 days and any activity, and we can review that, and then we see if we can make adjustments. So no point telling people theoretical diet that they're never going to eat. It's good to know what they want to eat and what they're willing to change. But you know, the guide to healthy eating is not really that difficult. We really want 50% of your dietary intake on your plate to be leafy green vegetables. We want a small amount, a quarter of the amount of protein, and a quarter of the plate to be carbohydrates. And then you want to minimize fat products and sugar products, including fruit. When people ask me what diet should I go on, we know that long-term sustainable diets are the important ones. And so, as I said, small changes early on, not to overwhelm people. If they want to look at evidence-based, then the Mediterranean diet has the best evidence base for metabolic parameters, and it's easy to follow, and we know it's palatable because a large swathe of society and cultures already eat this sort of diet. The CSIRO has done a fair bit of work as well in the diabetes and the dietary space, and for patients wanting an Australian flavour, I say, look, just have a look at the low-carb diabetes diet available at all the major supermarkets and shops and ordered online, which again gives people recipe ideas to get them started to think about what is a low carb diet, and not too dissimilar to the Mediterranean diet, which is, you know, we don't want too much energy from carbs, being a low carb diet, a bit more protein, lots of fiber, not too much saturated fat. Monitoring of blood glucose in type 2 diabetes, as you all know, has not been recommended for quite a while now as routine testing. However, I think it is good that patients have access to be able to do that in short bursts, because random glucose monitoring is a waste of time. So getting them to check their sugars once or twice a week is not helpful. And that's why it's been removed, because we wasted a lot of money on strips that went out of date, and a third of our diabetes budget actually goes on glucose strips. But where it's useful is if you get them to do intensive monitoring. So those 3 to 4 day food diaries, we get them to monitor 6 or 7 times a day for a few days, because that gives us a lot more information about what's happening, whether they're getting prandial rises, what causes their prandial rises, and allows you to adjust both their lifestyle and dietary factors, as well as looking at what treatment approach you might want to do. If they're at risk of hypos from treatment, then obviously they are approved for glucose monitoring. So if you're on insulin, or you're on sulfonylureas at doses where you're at risk of hypoglycemia, or you've got a job that you need to avoid hypoglycemia and you're on sulfonylureas, then you should have access to glucose testing. If you've got a HbA1c that is unreliable, then clearly glucose is the only way for you to know how their diabetes is going, and that's where glucose monitoring is helpful. It also allows you to identify when HbA1c is unreliable, because either the glucose is wrong or the HbA1c is wrong. If there's a discordance, and that helps you to work out which one. It's also helpful for patients to understand how their lifestyles impact on their diabetes, and that's why I think 3 to 4 days of intensive monitoring gives us a lot more information to work with than several months of random glucose at home, because patients can then see what that drink does to their sugar readings, or what that particular piece of fruit does to their sugar readings, and different people respond differently, unfortunately. So there's still a lot of individual variability. Currently under COVID, the 6-month applications have been suspended, but at some point it will be reintroduced once the COVID situation settles down. I think you've all seen this, hopefully, but the Australian guideline has been updated a couple of times in the last year, so I've just had to update this slide again tonight. But, you know, the Australian guidelines try to assist you with management. So as you say, you put them on metformin, either in the pre-diabetes or in the early diabetes phase. Metformin will reduce the HbA1c about 1% when it's used initially with lifestyle. After which you do need to think about, well, what am I going to add? And the Australian guideline does take into account PBS consideration, and that I think sometimes make it harder rather than easier to use, because what you'll see is that first line therapy, metformin, and then you could use sulfonylurea if you've got a very high starting point and you need to start early, or you can use insulin if you're very high in that first stage. And then after that, all the options are open, and after that, all the options are open. And they've tried to highlight the preferred options in dark blue, and they put little signs as well so that you can see which ones has heart benefits, which one has kidney benefits, and which ones have heart failure evidence as well, so that you can individualize treatment for your patients. And then obviously third line is whatever you haven't used before, and then right at the end, when you're looking at, well, what do I do now? Because now if they're not on insulin, the fourth line is going to be insulin, or you're going to send them along for us to think about why it's not working, or you're going to have to review what the issue might have been. On the back of the Australian guidelines is a table that talks about the evidence base as well as side effect profiles. I've tried to combine it into this one table. This is recorded, so you can have access to these pictures down the track. But I think we pretty much, the take-home message is that with oral agents, the first agent you're going to use, which is metformin or sulfonylurea under the PBS, will give you about a 1–1.5% reduction. That's what you should expect. With every second and third agent you add on, you can only expect another 0.5% reduction. So if you're 10%, going to a second agent, you might get down to 9.5%. Going to a third agent, you get to 9%. You're clearly not going to get down to 7% if that's your target with drugs alone. And that's why lifestyle is still very important. And that's why you might need to think about non-oral agents with more effectiveness. Sglt2 inhibitors, the worse you are, the bigger the effect. So if you're starting off very high, then you get a bigger drop in HbA1c. But you also got to be very wary of DKA with Sglt2 inhibitors. So we don't recommend that you start these if HbA1c is above 9% without coverage of insulin, because if your HbA1c is 10 or 11%, you're probably already insulin deficient and your risk of DKA is much higher. But the Sglt2 effect is more pronounced the worse your HbA1c is. So if you're about 7%, 0.5% is what you're going to get. You know, if you're around that 8 to 7%. If you're at 9%, you'll get a little bit more because of the way it works. The cost is on the Australian guidelines because a lot of our PBS is driven by costs, which is why it's there, but it may not be in the patient's individual interests purely on costs, but certainly it is from a society-wide perspective. And then cardiovascular safety has been mandated by the FDA. So we do have cardiovascular outcome trials for the newer agents. We don't have it for the older agents. Sulfonylureas, being such old agents, we don't have cardiovascular trials, but I guess there are concerns about how safe it actually is, given the risk of hypoglycemia. And metformin, we know through the long-term UK PDS studies that it is safe and effective, but it often takes a number of years to see that, at least 10 years to see that cardiovascular benefit from metformin. I'm going to move on to incretin therapy because I think this is where these are the sort of agents where I think understanding pathophysiology, we probably should be using them earlier, but the cost is a main limiting factor and the fact that currently they're in injection, but they are not painful injections and they're now, you've got once a week option. And I think once people get past the initial idea of giving themselves an injection, which doesn't hurt and is easy to do in once a week, a lot of people are very comfortable doing this. But GLP-1s and incretins, we've known about since the 1970s, but have only had access to them pharmacologically. So these are hormones released by your gut when you eat food. There's always a basal secretion even when you don't eat food, but once you eat food, there's an increase in the amount, and the further the food travels down the gut, the stronger the release becomes. Our native hormones are broken down by DPP-4, and that's where those DPP-4 inhibitors come in, so that you could increase your endogenous longevity of the hormones that you make. The GLP-1 analogs are not broken down by DPP-4, so there's no role to give people DPP-4 if you're trying to prolong activity of analogs. And the amount of GLP-1 when we're injecting it is about 1,000-fold, so it swamps your native GLP-1. So the trials of using DPP-4 inhibitors with GLP-1 analogs did not show any benefit, which is why you can stop the DPP-4 if you're going to move on to a GLP-1. So what the gut hormones does is it tells the body a few things. It tells your pancreas, make more insulin, stop making glucagon. So GLP-1 and GIP boost this insulin increase, but GLP-1 is the one that turns down the glucagon. And by that, you reduce the liver output and you increase the glucose uptake in the muscle. And at the brain level, the GLP-1 also increases satiety. So you eat less, and that's why weight loss goes along with GLP-1 treatment for at least half the patients in the trial, and in the newer agents that are coming through, the majority. And that's how it works from a diabetes perspective. It's also shown that GLP-1s promote beta cell survival, which I think, as we remember from talking about getting older and losing our beta cell, it may actually allow us to avoid the need for insulin for a longer period of time. So these drugs are certainly changing the way we look at diabetes and how we manage diabetes. And as I said, I think they've got a good role in the pre-diabetes space if they didn't cost so much. But they're all under patent at this stage. So there's 3 on the market. Bydureon has now been removed, but you've still got immediate release Byetta, dulaglutide, which is Trulicity, and semaglutide. And they're all approved as second-line therapy after metformin if a sulfonylurea is contraindicated. People lose an average of 3 to 5 kilos. That's the average weight loss with our current GLP-1s at diabetes doses, but you'll always find that there are certain patients who will lose more and some who don't lose any at all. The expected HbA1c reduction is more similar to first-line therapy with metformin and sulfonylurea, so you can expect a 1 to 2% reduction in HbA1c, which again makes it more promising as a second or third line agent than the 0.5% you get with orals. In the more recent trials, looking at renal protection and cardioprotection from heart attacks and death, as well as weight loss benefits, the long-acting GLP-1 have those trial data, which is why on the Australian guidelines, you'll see the little hearts and the little kidneys. Biggest side effect is gastrointestinal. So warn everyone that they are at risk of nausea. That settles the longer they stay on the treatment, and by 6 months, most people have overcome nausea. There is a group of people, about 1 in 20, where the nausea does not settle and is so debilitating that they'll need to stop the GLP-1. But I try to get them through at least the first month, if they can, before we call it quits on GLP-1. About 15% will complain of diarrhea, and about half will, again, so 5 to 8% or so will complain of constipation. So again, the diarrhea tends to settle with time. The constipation tends to not settle, but is usually easily managed with more water, fibre, and a bit of colloxin if you needed it. As we mentioned, you can only expect a 1 to 1.8% reduction, which means that if you're above 10%, then GLP-1s are not going to get you to target. And the government also recognises the metabolic benefits with weight loss and appetite reduction, so needing less insulin. So on the PBS, you can now use Byetta with insulin or Trulicity with insulin. We'll see what the PBAC decides about semaglutide later this year. But currently, you could give people Trulicity with insulin if you need to get them to target. I'll go briefly through Sglt2 inhibitors because they've been around now for a number of years and they're not that new anymore. And their interest is not really in their glucose lowering effect. So their glucose lowering effect, as I said, 0.5 to 1%, which is not too dissimilar to a DPP-4 or sulfonylurea. So the kidneys is part of that ominous octet. In diabetes, the glucose transporter, the SGLT2, so it's also a sodium transporter, is upregulated. So normally you should have a net balance, which is the kidney filters all the glucose and then you reabsorb the filtered glucose, which in a normal person is about 180 grams per day. But with diabetes, they filter more glucose, often because they're eating more glucose for some people, but they also upregulate the return of glucose to the system. And that may not be what you want when you're already hyperglycemic. So what these drugs do is block the Sglt2, which is in the first part of the proximal tubule, the first and second part, to reduce that resorption. And that way more glucose and more salt is then excreted out through the urine. There is other pathways to resorb glucose down the track, but it doesn't do much of it. So by blocking this, 90% of it is done by the Sglt2 inhibitor, and there's a little bit of Sglt1 down the track. But that extra salt and glucose wasting is where things have become more interesting. Because up until the cardiovascular outcome trials, we weren't very interested in Sglt2 inhibitors. Our patients were already glycosuric, they're already peeing and polyuric, and we get 0.5% reduction, and they already got thrush and urinary tract infection, which is increased 5-fold with these drugs. And so for a lot of us, we're like, I don't really see the extra benefit. But the outcome trials for the cardiovascular disease have changed that. And so for this made quite a lot of news at the time. So they published this in empagliflozin, published theirs first, but we've since had canagliflozin and dapagliflozin publish theirs. And what they showed is that not only is it safe, but it actually protects people from heart attack, and it protects people within the first 2 years, which is not what you'd expect from a HbA1c reduction of 0.5%, because it took us 10 years to show that metformin protects you from heart attacks. And in particular, if you look at D, it protects people from heart failure. And so people have gone back and have a look at the mechanism of why this may be, and it may be that it's more to do with the sodium blockade of the Sglt2 rather than the glucose blockade. But certainly there's now incontrovertible proof that these drugs protects people from heart attacks and death from heart attacks and hospitalization for heart failure. And so in those patients who are at high risk of this, we really don't have a reason not to if they're going to live more than 2 years, because we can see the benefit in that first 2 years. And the number needed to treat was not that high, which means that for every 39 patients given an Sglt2, in this case EMPA, we protected one person against death in that first 3 years. There's been quite a lot of pulling together of all the different cardiovascular and renal outcome trials. I'll just show you some of that data in a condensed format. So looking at all the trials to date and this is about a year old now, looking at GLP-1, so you can see that, dulaglutide, semaglutide, exenatide, to a lesser degree, if you've already got a heart condition, you've had a heart attack or you've got angina, then both these drugs reduces your risk of death in the combined outcome. If you haven't had a heart attack or you don't have established disease, but you've got lots of risk factors, then we don't know that they are actually going to be protective, which is why the DAPA trial, for example, which included a lot of people with multiple risk factors, but didn't include as many people with established disease like the EMPA trial, wasn't showing that same positive effect. Heart failure is quite clear that the SGLT2 inhibitors are superior. So if you're debating between, do I give my patient a GLP-1 or do I give them an SGLT2, because under PBS you can't give them both, then SGLT2s wins hands down from heart failure perspective, and dapagliflozin is actually approved for patients with diabetes and heart failure, irrespective of the HbA1c in this, because of this reason. GLP-1, they don't do anything to to cause you to lose salt or drop your blood pressure. So not surprisingly, no effect on heart failure, although a tendency to improvement, perhaps because of weight loss that you see with GLP-1s. In terms of renal outcomes, as I said, both of them have effectiveness. It's much clearer for Sglt2 inhibitors because they lower blood pressure more significantly. So the renal physicians, if you've got someone who's got microalbuminuria or macroalbuminuria, or even just kidney disease without albuminuria, you want that person to be on an Sglt2 inhibitor. There is a benefit looking at Sustain, which is semaglutide. XL is lixisenatide, which we don't have in Australia, but liraglutide and semaglutide, there is improvement in kidney outcomes as well. Once you get to macroalbuminuria, then the GLP-1 effect is not so clear. So once you've got more than microalbuminuria, Sglt2 inhibitors have much stronger evidence. Sglt2 inhibitors, though, are much cheaper than GLP-1, and scientifically, because they work differently, there's no reason we couldn't use it theoretically. It's just who pays for it under PBS. And so for those of you who have done alliance with myself or Dr. Acharya, you'll realize that if patients can afford $33 a month, we get them to pay for the Sglt2 on private prescription using half dose of the maximum EMPA, which is 12.5 milligram, which is what the EMPA-REG trial used, 10 to 25. You can get that benefit and still allow the GLP-1 on PBS. This is the canagliflozin renal outcome trials. So this is the first dedicated kidney outcome trials, and this is one of the reasons why the cutoff for GFR for both GLP-1s and Sglt2s has been reduced over the last 12 to 24 months, showing that if you've got someone with kidney disease, microalbuminuria, or a raised eGFR or macroalbuminuria, then again, over that 2 to 3 year period of the trial, we could prevent progression to death or end-stage kidney disease with a number needed to treat of somewhere between 25 to 40 or thereabout. I'm going to skip past this because I've kind of talked about this already, which is, as we said, the mechanism behind why they're so good for heart failure and kidney disease is probably more to do with the sodium rather than the glucose, although it's approved for diabetes. And so by blocking the sodium in the glucose, not only do you excrete more glucose, but you deliver more sodium to the distal collecting tubules where the macula densa is. And the macula densa then sends a signal back to the glomeruli, to the Bowmans, to cause constriction of the afferent arteriole. And by causing that vasoconstriction, that hyperfiltration that damages the kidney is reduced. It's also why you should expect to see an eGFR drop when you first start an SGLT2. And that's why the kidney doctors will say, don't worry about the fact that the eGFR drops. We want you to, we expect it to do that, but in the longer term, it will protect the kidneys from long-term damage from the hyperfiltration and from the pressure, and is beneficial. I'm going to skip past that because that's just a close-up. So what's the recommendation now? Well, if your kidney function is down below 45, then the recommendation is that metformin be reduced by 50%, so maximum dose of 1 gram per day. All the DPP-4s need a dose reduction at this point, except for linagliptin. And we don't recommend you stop Sglt2 inhibitors now, even though the PI is now saying 30 before you need to stop. But Credence, as well as the DAPA trials, kept people on their Sglt2 down to a GFR of 15. And Dr. Bobby Chaco would say that he will keep them on until they get onto dialysis. Because as long as they're making urine, these drugs are protecting the remaining glomerulus. But certainly, we don't recommend you stop Sglt2 inhibitors until the GFR is below 30. But at that point, you want to send them to the nephrologist, who will then take on the responsibility of continuing the Sglt2 inhibitor. Under GFR of now 15, actually, for Trulicity, because of the renal trials, you should think about reducing GLP-1s. And that's mainly because of the nausea, because if they're vomiting and they get dehydrated, they might get acute kidney injury. We don't use sulfonylureas with renal failure because they have active metabolites. They tend to accumulate, and hypoglycemia becomes a bigger problem and is more prolonged. So once the GFRs are below 30, we recommend that you stop the sulfonylurea and you move on to insulin, which is short-acting and which you can control more carefully. At the end stage, if they're already on insulin, you do need to think about reviewing dosages for insulin, because again, hypoglycemia is more risky because the ability for gluconeogenesis is reduced at the kidney level, as well as the potential for longer action time. And I think this is my last slide, which is the primary prevention. So when do you talk about primary prevention? Obviously, we want to use statins in everyone who's had an event, but primary prevention if you're above 10%. Also think about it as primary prevention because there is evidence for statins to protect for kidney disease, although, as I said, SGLT2s have kind of replaced that role in the kidney space. And think about using it early because Aboriginal and Torres Strait Islanders are at higher risk of death for cardiovascular disease, and they aren't represented by those risk calculators. So they may not apply in our Aboriginal and Torres Strait Islanders. If you are going to use it, the target is to get LDL under 2 if it's primary prevention, under 1.6 if it's secondary prevention, and total cholesterol less than 4, or 50% of your cholesterol should be, less than 50% should be LDL or non-HDL. ACE inhibitors are preferred for hypertension as first line, and also for anyone with microalbuminuria, regardless of blood pressure, provided that they're not having troubles. When we use it for blood pressure, it works better, and this is in the last 12 months. The Hygia trials have shown that if you give your blood pressure tablets at night, you get more benefit and you prevent more strokes and heart attacks, so hard endpoints of vascular outcomes if you give it at night. And that kind of makes sense because it means that the time at which I needed to work most, which is that early morning adrenaline and cortisol rush when people get most of their strokes and heart attack, they've got the best blood pressure control. Aspirin is recommended as secondary prevention, and we're still not certain about primary prevention because we cause as many major adverse GI bleeds as we protect. So again, I think when you're looking at primary prevention, you look at your patient, and if they're at high risk of a GI bleed, I wouldn't use it for primary prevention. If they're not at risk of a GI bleed, but they're at a much higher risk of a cardiovascular event, then I would consider using aspirin as primary prevention. Fibrates is not approved except for hypertriglyceridemia, but we know from the Field Eye study as well as from other retinopathy studies that it does protect against progression of retinopathy, and it is TGA indicated for this, but not PBS approved. But not many of my type 2 diabetics will not have high triglyceride or hypercholesterolemia. And again, they're pretty cheap and off patent, so we use these for anyone who's got retinopathy as a prevention of progression. And it's got some weak evidence for cardiovascular risk reduction as well. I'm ran out of time, so I won't talk about NDSS except to say, please register your patients. The data is very helpful for government policies, and also helpful because the NDSS does send out information to patients and have a lot of resources for patients with type 2 diabetes to help support, including access to things like through Diabetes Australia, things like diabetes educators and dietitians. I'm going to show this one only because I don't find the Australian guidelines very helpful, and all the things I've talked about with management is encompassed by the EASD ADA consensus. So this is the European and American coming together, looking at the latest data on the renal and cardiovascular trials of the SGLT2s and the heart failure to help you guide you on what is best on science, not just on costs for individual patients. So if you've got someone, you've used metformin, they're above target and they've got established kidney disease, then we want to use an SGLT2 or a GLP-1, and the third line will obviously be one or the other. If they've got heart failure, then the SGLT2, as I've shown you in the previous trial evidence, clearly wins. So in this group, you'll go straight to SGLT2 as your second line agent. If they don't have established kidney disease or they don't have established heart disease, and you're worried about hypos, then you'll pick something that doesn't cause hypo. So these require insulin, these require glucose for their activity. And that's where you can use a GLP-1 or an SGLT2 or a DPP-4. TZDs we don't use a lot of anymore, but it's the only other insulin sensitizer. So I use TZDs in young people with good hearts where I'm not worried about the fluid accumulation, who are very insulin resistant, where I'm struggling despite the addition of a GLP-1, despite metformin, where I might want to improve insulin resistance. I wouldn't use it for older people where there's risk of fractures or heart failure. If you're trying to avoid weight gain, then GLP-1 is the best agent. SGLT2 is second best agent, not as much weight loss as a GLP-1, but cheaper. And then this is where our PBS comes in, where if cost is a big issue and the patient has to pay for these drugs and they really can't afford to pay for it, then the cheapest thing to use would be to use a sulfonylurea or the TZD, which is pioglitazone, because they're all off patent and they're quite cheap. So I think the EASD consensus is much more individualized, much more science-based. It doesn't take into consideration cost as the primary driver, unlike our PBS, which makes it hard when you're trying to individualize that for the person in front of you. I won't have time to talk about these last few cases, so I'll stop and see if there's any questions that people have.
I haven't had any more questions come through. So we might just finish there, I think. If we do get any more come through, I can send them to you anyway, Judy, and we can have a look. I just wanted to remind everybody that on Thursday night we have MasterClass number 2, and it starts at the same time, which is 6:30. I've just got someone comment for learning. What will be the answers for 2 cases? Oh, so for that case that you spoke about earlier, I did have a few people put in an answer, which was there was no OGTT.
Yep. So the case with the sugar above 17, or even a fasting above 12, we don't want to use OGTTs. We really want you to either repeat a glucose level, fasting or random, or do a HbA1c. As I said, we use OGTT for the borderline cases where you really want to know the answer. But I think given that it's a spectrum, it's a bit academic for a lot of people, whether you call it pre-diabetes or early diabetes, except in the settings of pregnancy, where it's very important for us to know because of the fetal malformations, or where there's a regulatory requirement that you need to know, like a commercial pilot's license, where you do need to say they do or don't have diabetes. Those are the settings. But young people under the age of 40 always think about type 1, regardless of whether they're obese or not. Check their ketones for anyone with a sugar above 17, because as I said, you can get type 1 at any age, and ketone tells you that there's insulin deficiency, whether that's autoimmune, whether that's glucose toxicity, or whether that's age-related beta cell loss, but it tells you that you need to get them on insulin earlier, whilst you're still trying to sort out which one it is. I guess that's the key message. So the take-home message really for tonight is please screen, because we're not screening enough people. Most of our practices, the average prevalence is about 6 to 7%, which is half of what we know the true prevalence is. And you can do it the complicated and official way, or you could just do the annual full fasting and HbA1c. Reserve your OGTTs for the complicated cases or the pregnancy cases, and always think about the type 1 masquerading in your clinics, because they are 5 to 10%, and it's very easy to test because you just order a GAD and a fasting C-peptide with a glucose, and you can determine if they're making enough insulin or not. We're always there to help. The Australian guidelines are there. Have a look at them. Your handbook is really good, actually, so worth a read. And if you just needed something to stick on your wall in your office, I use the EASD guidelines, because it condenses all that data that I've just given you into this is an approach for that individual person. Great. So hopefully those are the take-home messages. It's taken me an hour and a half to do that in 5 minutes.
Thanks very much, Judy, and we'll see you on Thursday night.
Great. Hopefully I'll see everyone there. We'll talk about insulin in a lot more detail on Thursday night, including how to start, what to start, who to start, and any other tricky questions about potential problems with insulin. Hope to see most of you there. Good night, everyone.
Bye.